Hello. So this is lecture 7, and we're covering racism and health. This lecture is actually taken from a curriculum developed by the Association of American Medical Colleges. And I've already uploaded the assignments and the slides for you to take a look at, and this will be uploaded here shortly. So come on, let's advance the slide. Let's see if I can about that. Okay. So why are we talking about this? We've kind of been talking about racism and sexism throughout this semester in regards to the American healthcare system. But I felt that there really needed to be at least one lecture just focusing on this. So basically, this, as you already know, the racism has been really within our system since the beginning of the United States um, through slavery, through the conquest of land, um, dehumanizing Native American populations, and etc. It really has is embedded within our system from the beginning to now. And we have, so how can we transform this? Really, we've talked about patient centered healthcare and community centered health, as well as health and wellness promotion, which many of you are already involved in um, through through the university or internships. And those of you that are going into public health, this will probably be one of your largest focuses. And honestly, equity um, among all will be a huge focus moving forward. Population health and community engagement. We've talked a bit about, I'm sure you've gotten it in other classes, and really emphasizing on health equity and not equality. You can have equality, but still not have equity, as many of you already know. Um, Race and racism are major social determinants of health and are very influential in access to quality health care within our system. So for this lecture, first we're going to define racism and race. I'm going to go a little more in depth on some of the historical examples of institutional racism within our system. We'll then differentiate the different levels of racism and how they can affect health. And then I'm gonna take a look at some of the tools that have been developed by the AAMC, and really I find these very useful just for you in your everyday life as well, if you can stop and think things through. Okay, so first, race. Um, Race is a classification of humans into groups based on physical traits, ancestry, relations, and the relationships between them. I did upload a TED talk from, I believe it's Dr. Jones. I have a quote from her. Um, it's actually, it's the Dorothea Roberts TED Talk. I And that is part of your assignments for this section. And really, she goes into this beautifully. She really breaks down how race is just a social construction. Um, we've actually made up these social groupings, right? There's really no rhyme to reason to them other than what you look like on the outside and possibly what you feel like how you feel that you socially determine who you are within society, right? There's when it gets down to the DNA, there's really no differences between anybody. These are crude, often inaccurate proxies for socioeconomic status. And we also use them a lot in medicine. Um, so precise measurement of classification of people in a race conscious society. We really, this is not a precise um, measurement of who we are, what we're made up, what our cells are, right? Racism is a system of structuring opportunity and assigning value based on a social interpretation of race. This is a quote from that TED Talk. Race is not a biological category that naturally produces these health disparities because of genetic difference. Race is a social category that has staggering biological consequences, but because of the impact of social inequality on people's health. So really, there is no, this throughout our history, um, our medical community and abroad have really tried to relegate different um, medicines, different ways of interacting with people, different procedures just due to race. And this is wrong. Like race does not have any um, relevance to medical or health. Okay, so just we've gone over some of these historic definitions of race shaped by science and medicine, but this goes in a little more in depth. I really like the way this was put together. Um, so, uh, and they go back to Linnaeus. So, Carl Linnaeus was a leading Swedish science botanist. Many of you have know of him. He developed um, the our system of naming things in the scientific um, taxonomy. Um, and he was also a physician of his time. So he developed this taxonomy of way to describe being Europeans with more favorable attributes, right? Just look at the words that he's using for Europeans: fair, gentle, acute, inventive, governed by laws. I find it interesting that this use of fair here, because not only is it portraying a skin color, but also a fairness, right? A way of people working together. And then he goes on to describe Africans as Black, crafty, indolent, negligent, governed by caprice. And often this use of, again, of color to define something negative, regardless of race or anything else. But just the use of these two words, Black and fair, really say so much more. Asiatics, sooty. I'm not even sure how that is, why that's described that way, why you would describe someone that way. Severe, haughty, covetous, governed by opinions. So again, very negative. So this is Americans. It should be Native Americans: copper colored, obstinate, content, free, regulated by customs. We're not exactly, these are very still in a very negative. And this, of course, is a way of putting Europeans up at a higher than these other races, right? Morton. So Morton was an American anthropologist and physician who used skull size measurements as a proxy for intelligence, claiming that Caucasians had larger skulls, which gave them superiority. Okay. He concludes that um, their larger skulls give Caucasians decided and unquestioned superiority over all nations of the earth. I need to find more on him and maybe have some extra readings, because this does go through this is kind of the beginning of the eugenics, which I have uploaded both a video on and some podcasts, which then of course this is kind of that groundwork into some of these other things that we're going to be talking about. Dawes rules measured the Indianness by blood instead of by clan. So these are policies that successfully forced Native Americans to agree to a land allotment plan used as an assessment of heritage based on the degree of Indian blood. So basically their ancestors, if your grandparents were of this tribe, or your great grandparents, how much Indian blood did you have within you? This, among other catastrophic historical insults, has led to long-lasting discrimination and health disparities among American Indian and Alaskan natives. And the Dawes rules are still kind of used today, not to this extreme, but you still have, it's still kind of on the books. So anthropologist William V. Ripley attempted to categorize whites into a number of subraces. So this is where we've talked about how Irish immigrants and Italian immigrants were treated in medicine previously, and this is how that kind of came about. And so, and this also led to, was later used to justify lower status jobs for off-white races, which then later influenced the Holocaust and eugenics. Of course, we've talked about the Tuskegee syphilis study, and I'll just remind you, this study followed the history of syphilis in poor Black sharecroppers. The participants were not actually purposely infected with syphilis. I don't know if I specified that previously, but they were not, but remember, they were not told that there was a cure either. And even after the discovery of penicillin and how well it worked on controlling the disease, and they were actively discouraged from seeking other treatment as well. And I don't believe I touched on that. And then, of course, once the public gained knowledge of the study in the 1970s, it caused a public outcry and helped to ensure protections for study participants. So 1933, the first concentration camp was established for diseased races. And by diseased races, this of course meant Jews as well as Gypsies. It also included many Eastern Europeans and other races that had brown toned skin. Despite the calls to end the race-based thinking in science, politics after World War II, Jim Crow laws, and the helped shape segregation. And this persisted throughout the United States and in California. We will talk about segregation within California as well. However, in 1950, the UNESCO declares there is no scientific basis for race. So we knew this way back in 1950, and yet it continues. Um, uh, but really, in the United States after 1950, this is after UNESCO declared this, that's when we started to see, and with African Americans coming back after World War II, seeing the differences in the way they were treated in Europe um, and the way that they're treated in the United States, lived li- started this um, civil rights, a lot of the civil rights laws, and of course activism. So 1996, so this is, recent history. Books and articles continued to emerge in the 80s and 90s that attempted to link the differences in outcomes to racial and biological differences, despite little evidence to support these claims. I mean, this is recent, right? And so just to read over this, Graham and Robertson argued that salt-sparing genetic variation was adopted in Africa due to chronic salt shortages. Enslaved Africans who possessed this variant were able to survive salt deprivation of the Middle Passage. There is virtually no evidence for this genetic variation or even salt shortages in Africa. Rather, evidence supports the hypothesis that social and economic inequalities generate chronically stressful living situations in Black Americans. Okay, and this, many of you probably have heard of this. It's, I was shocked when it came out. The FDA approved a drug intended for self-identified Black patients. And she talks about this in her TED Talk too. It's really, they had no actual scientific, it was not scientifically based. It was a sales scheme. It was very interesting, and you'll hear more about that in the podcast. So history of race relations in our community. So of course, in California, although we like to say that we're that we don't have issues of race, we all know that that's not true. We have a long history of segregation from the beginning of the state to now. So of course, those of you from California will already know some of our history and of the Spanish conquistadors and the Catholic Church coming up through the state, enslaving Native Americans, and really causing and killing off many of our tribes here in California. This segregation continued and expanded really to those of Chinese descent who were now, from the beginning of the state, were never allowed to own property. To the during the gold rush, we had what was called scalp bounties for Native Americans. And I think I will have to double check the price, but I think it was like $1 a scalp, which in those days was huge. And so people would just go out and wholesale slaughter Native Americans, and to get the scalp bounty. That continued, actually that expanded into many Asian communities as well, where they would scalp the Asians and Chinese immigrants to get the scalp bounty, to the point where instead of having this just the scalps, the government insisted that they brought the whole head. It is disgusting and unbelievable, but they also, but it really didn't, they would get paid either way. So I don't, it, it's actually led to the elimination of whole tribes within California. For instance, the Shasta Indians, they're no longer. Of course, the Karuk tribe is a subset, or is an overall, I'm gonna have to think about this. The Shasta Indian tribe was a part of the Karuk tribe, but that is a whole leg of that tribe that is no longer with us today, and many other tribes. Redlining was very prevalent here in California. And basically what redlining is a systematic denial of various services or goods by the federal government, agencies, local governments, or private sectors, either directly or through selective raising of prices, as well as denial of loans. So after World War II, many veterans came back. And in order to help support them, the government had VA loans for college tuition, to buy homes, and many other things, to start businesses. However, VA loans were denied to many, and I don't even know if any African American veterans got VA loans. I wouldn't say none of them did, because there was probably a couple. They also denied farm loans to African American and Hispanic farmers. And this continued throughout our history up until just a few years ago, when the USDA was sued over it. But in the meantime, many minority farmers were unable to keep their farms and lost their livelihoods. So this is kind of this is really that those building blocks, right, that were denied our African Americans and Latinos throughout the history. And these more recent denial of VA loans and farm loans really led to what we have now, is a lack of socioeconomic status within these populations, and of course lower health as well. And we're going to talk more about some of this redlining around the local area. We do have a guest speaker who's really looked into this in Stanislaus County, and some of these laws are some of these HOA or rules are still on the books, and they're still on some deeds of property within these two counties, where the property cannot be sold to African Americans, Asian Americans. I think they have Hawaiian Islanders. It's really crazy. And that these are still, they haven't been struck. And so we're going to talk a minute about Japanese internment and loss of farms in this area. So when the Japanese, we had a large population within the Central Valley, especially within our northern San Joaquin Valley, and I believe even down south, but really of Japanese farmers. And when the United States interned Japanese people, many of these farmers lost their farms. And so this statue is here in Merced over at the fairgrounds. In Merced, they actually had, oops, Merced was actually a holding facility um, for these, for Japanese Americans before they were shipped to other internment camps. So we're going to quickly look at, maybe we are, this will allow me. Let me stop share real quick and see if I can pull this up. Okay. For some reason, I always have this problem with this. Okay. It's not going to let me. All right. I'm going to continue on. And then my computer's acting kind of funny. I'm going to just go ahead and continue on, and then we will get to that. Hold on. Sorry. Hold on just a second. Hopefully. Let's see if I can share screen 2. Okay. Okay, so we're going to talk about levels of racism. So we have institutional, personal mediated, and internalized. So first we're going to talk about this institutional racism. So what is institutional or structural racism? It's differential access to goods and services and opportunities of society by race. It's normative, sometimes legalized, structural, codified in our policies, governments, and institutions. There's no identifiable perpetrator and often is evident as an inaction in the face of need. So what does this mean? So often institutional racism is just the attitude within the institution itself, right? There's even on the books, they could have all of these laws or rules against racism, but it's really it's embedded in the structure of the company or organization. And often what happens is this this type of racism really shows up when someone comes and has an issue on hand. There's an employee, just making rude comments, or the just making rude comments is a part of institutional racism, right? And they go to a supervisor who's like, oh, they were just kidding. They're just kidding. We've dealt with this a lot more around sexual harassment than I think we have around racism. So how I think this is actually a great, I really like this metaphor here. And this was developed by Comrade Jones. And if you want to look more at kind of some of her work, this is the link to it. So if we look at unearned privilege, so white privilege is basically what we're talking about here, especially white male privilege. We're looking at, and we look at it in the context of growing a garden. So under-earned privilege is here, that is that fertile soil. So this is your miracle grow soil, right? It's got all the nutrients you'll ever need to grow the best flowers. Unprivileged is, just grabbing that soil out of your yard. Maybe it's good, maybe it's not. Maybe it has some support in it, or maybe it's just rocks. You don't know. But here's that dry, rocky soil. So we add into that our seeds, right? Or this is that historical insult. So maybe that gardener prefers red flowers. So they're going to make sure they plant those red flowers in that fertile soil. And they don't really like those pink flowers. So they're going to plant, they don't care whether they grow or not. And as a gardener, I have done this. So you just kind of plant those, out in your garden somewhere. No big deal. If they die, they die, whatever. Okay. So of course, then, these flowers start to grow. And of course, these red flowers are doing wonderfully. They're beautiful, they're lush, they've got all the nutrients. And these pink flowers are really trying just to make it, right? They're not doing as well. And so these are those societal norms and structural barriers that persist generation after generation. So generation after generation, these red flowers have been given the best. They've gotten the best soil. They've gotten access to healthcare. They've gotten access to education. In California, you can even say they've gotten a better education because of the way we fund our schools. So here in California, the schools in a neighborhood are funded by the tax base in that neighborhood. So if you're in a better neighborhood, those schools are going to get more money. If you live in a poorer neighborhood, you're only going to get the money from that neighborhood. They've tried to restructure it a bit, but it's really not, hasn't been done. So your rocky soil is your education, it's your or lack of education, your lack of technology in your school system, your lack of brand new books, the lack of computers, um, your teachers don't earn as much, all of these things. So the Gardner subscribes to this concept of biological determinism. So here we get back to that inaction in the face of need perpetuates inequality, right? And this is passive, like no one's directly trying to kill off these flowers. No one's directly um, uh, hurting them in other ways. It's just these minute ways that are continue. The lack of affordable housing, the lack of healthcare, the lack of education, the lack of um, uh, healthy food in a neighborhood. So who is this gardener? So in this metaphor, the government, the media, other corporations and foundations are the gardeners, right? And the communities themselves. But this is very dangerous when it's allied with one group. So right now it's allied with white upper social economic status people, right? Or groups who are not concerned with equity. They'll talk about equality like it's the same thing, and it's not. So how can this affect health? All of you have taken classes and learned about health disparities related to the social determinants of health. So there's poverty-related illnesses such as low birth weight, infant mortality, asthma, infectious disease, cancer, depression, all these things, cardiovascular disease, um, unhealthy default decisions. So food deserts, grocery stores don't go into these neighborhoods. You're left with, just the corner markets. And some of them are good, but most of them don't have everything you need. Smoking, uh, cigarette companies actually advertise more in these communities than they do in other communities. Toxic environments, lead contamination in the water. We know this with Flint, and there's other communities within California. And of course, trauma, greater risk of injury and suicide. This is shown within the American Indian and Alaskan Native, as well as the African American communities. Access to quality healthcare. So there's limited health literacy. We talked about the inadequate education on health, lower levels of insurance coverage, marginalization, low physical access to healthcare institutions, distant neighborhoods, crumbling infrastructure. Rural areas, of course, are notoriously do not have enough doctors. And of course, underfunded health systems. We're going to talk a bit about this. So we're going to talk about Native American and Alaskan Natives. We haven't really talked about them much this semester. So in the 2010 census, there's over 4.2 million Native American and Alaskan Natives within the United States. They have the highest poverty rates at 28%, which is twice the national rate. 18% of Native Americans lack health insurance. About 28% over the age of 5 actually speak a language other than English at home. There are currently 566 federally recognized tribes. Just a second, I'm going to this slide on my side. So these are some of the major contributors to premature death among American Indians. Diabetes is huge. TB, 4%, infant mortality rates at 2%, which is much higher than our national average. Intentional injury, 8%. This is where we kind of start getting into the high rates of suicide, but this unintentional injury, I'm not exactly sure what's in this category, but this is huge, 30%. Other could be anything. And then, of course, alcohol induced at 20%. Oops. Indian Health Service. So Indian Health Service provides care for about 2.5 million Native Americans. So it's basically approximately half of our Native populations go to an Indian Health Service. There's actually 3 branches. There's a federally operated direct care program, independent tribal operated direct care program. And this, I believe, is mostly what we have in California are these independent and small urban healthcare systems. Quality improvement has been hampered by a shortage of funding almost since the beginning to provide needed health services and there's also a limited availability of clinicians for the population. And back in 2013, they actually received another budget cut of $800 million in an already dwindling budget. Indian health has improved in several quality measures, however, over the past 10 years, but it still remains below Medicare quality. In a survey of Indian Health Service physicians, they reported a low rates of access to high quality specialists, low rates of access to high quality diagnostic imaging. And this is super important because many of these are located in rural areas. So it's not like they can just go to the next hospital. It's more like they have to go to the next county, which could be hundreds of miles away. Low access to high quality outpatient mental health services. And this, of course, is that lack leads to those high rates of suicide as well. And low rates of access to non-emergent hospital admissions. And again, the hospitals may not be anywhere close to many of these facilities, right? A lot of them are in rural areas. So physician surveys cited lack of geographic proximity and lack of funding as very important barriers to accessing specialty care. So what are we looking at? We are looking at an increase in healthcare delivery, a greater need for healthcare delivery, and lower access and lower, which will then lead to lower quality of care. So let's talk about police killings and their spillover effects and mental health. So this is a study that actually took place prior in 2013, 2015 by the CDC Behavioral Risk Factor Surveillance Systems surveyed. And this is also combined with national data of police killings. And what they found was of basically 34,000 of 104,000 Black American respondents were exposed to less than one police killings of unarmed Black Americans in their state in the 3 months prior to this survey. So this is the people that they surveyed. With each additional police killing of an unarmed Black American, it was associated with 0.14 additional poor mental health days during this time period, among Black American respondents. However, there was no impact on white respondents. So what are they saying? They're saying that police killings of Black Americans, regardless if they know who that other person is, if it took place within their state, it is leading to poor mental health outcomes and could contribute to 1.7 additional poor mental health days per person per year, or 55 million excess poor mental health days per year. So this could also lead, what they're saying here is it leads to lead to people calling in sick from work. It could lead to longer sustained mental health issues in the future. And this again is prior to everything that's happened over this past summer. So I'm sure this has increased. So we're going to move on to personally mediated racism. So prejudice is a differential assumption about the abilities, motives, and intentions of others according to their race. Discrimination, differential actions. So those are those actions, others toward others according to their race. And these can be intentional or unintentional acts of commission as well as omission. So the way these manifest themselves as just an overall lack of respect for a person or a community, suspicion, and we see this a lot within, my husband really likes to watch these cop videos. They make me crazy and just really upset me. But that's what you see all the time in some of these, person's getting pulled over, and immediately, if they're a person of color, they're suspected of committing a larger crime than maybe just speeding. Devaluation, scapegoating, and dehumanization. So how does this affect health and health delivery? So minority Americans are less likely than whites to get many effective medical and surgical services across a variety of clinical settings. So they often get inferior pain treatment. They're not given the pain medication needed for, and we've already talked about this, for surgery, for for other health conditions. They're looked at as one, being able to withstand more pain, like we've talked about before, or also just complaining that they're in pain. They're in more pain than they are. So this also has led to lower rates of revascularization procedures for acute myocardial infarction or heart attack, because doctors don't believe that that's going on. They believe they're complaining, or they believe there's something else going on, because it may not, especially among women, it may not be um, seen as a heart attack. So fewer prescriptions are given for beta blockers after a heart attack. There's less timely administration of antibiotics for pneumonia. And this could be due to many factors, one being race, but also lack of quality healthcare. Less optimal care for diabetes, fewer prescriptions for inhalers in children with asthma, fewer cancer screenings and tests, and it goes on and on. There's many others, and you can read more about these in the paper by Smedley. And it's also associated with poorer health outcomes. So hypertension and poor sleep quality among African Americans, lower uptake of diabetic services among American Indian women, increased frailty in Asian Pacific Islanders and Latino elderly, increased sexual behaviors in MSM, not sure, of color. I didn't make this slide, so I'm trying to think what that would be, and I just missed it. Preterm birth of African American women. I'm trying to think. So all of these you can look up and really get. So of course, this has all led to an overall distrust of healthcare and research. So how often, if ever, do you think physicians prescribe medicine as a way of experimenting on people without their knowledge or consent? Fairly often, or do not know. So the top is white people who are surveyed, and the bottom is Black. And there's almost twice as many African Americans that believe that they are experimented on. And of course, they have a history of that, right? Do you believe that physicians have ever given you treatment as a part of an experiment without your permission? Only 8% of white people, but over almost a quarter, or actually you could call it a quarter of Black people believe that that has happened to them. So internalized racism, acceptance by members of the stigmatized races of negative message about their own ability and intrinsic worth. And this manifests as self-devaluation, resignation, helplessness, hopelessness, and a stereotype threat. What is a stereotype threat? It is an unpleasant psychological experience of confronting negative stereotypes by one's own race, ethnicity, gender, sexual orientation, or social status that can impair intellectual functioning and interfere with test performance. This is associated in multiple poor outcomes: lower healthcare utilization, higher stress levels, lower performance of neuropsychological testing, and higher blood pressure. And this also can be is also found within women as well. Women in power are often harder on other women coming up. So this is definitely a problem within populations that have been um, uh, um, uh, uh, populations that have been pushed into lower status. So what can we do about this? First, we can advocate, right? We can advocate for better healthcare. We can advocate for the university to have better systems in place. We also need to build trust within these populations and communities. Have empathy, understand what's going on and how this has been a historical issue. And self-efficacy in your relationships with patients or when you're working in communities. Learn and teach others. Mitigate that unconscious bias. Understand when it's when you have it too. And this is something I've really been focusing on in myself as well as with my kids. Create non-threatening strategies to address bias when you recognize it in a clinical encounter or a community encounter. So opening up the dialogue, Black Lives Matter and medicine. So I don't know how many of you are familiar with White Coats for Black Lives. I think I've posted pictures and so the vision of is to safeguard the lives and well-being of our patients through the elimination of racism. The mission statement: to eliminate racial bias in practice of medicine and recognize racism as a threat to health and well-being of people of color. The communities and patients' perspective of illness, and we've talked about this a little bit with the Black trust. So basically, there is distrust there. You have to understand there is trust. There's always going to be concerns about discrimination and disempowerment within these communities. And we really need to elicit the patient and the community's perspective of illness to enhance trust, empathy and understanding, shared decision making, and patient engagement and autonomy. So if you never join a protest or advocate for a policy, what can you do? Studying and acknowledging these issues of race and racism can make a difference in day-to-day care of patients and when you work in communities. Increase how much you value health equity and remember what health equity is. Reducing unconscious bias by getting to know patients on an individual level. Reducing patient blame by recognizing the larger competing priorities and discriminations in their lives and life histories. Mobilizing diverse teams to maximize teamwork, supporting and empowering yourselves and your colleagues. I think just understanding what has happened and what people are going through, having that empathy is important as you move forward in your careers. So I really like this, taking charge squared to mitigate your own bias. So C, change your context. Is there another Is there another perspective that is possible? Be honest with yourself, acknowledge and be aware. Avoid blaming yourself. Know that you can do something about it. Realize when you need to slow down. Get to know people you perceive as different than you. Engage, remember why you are doing this. Empower your community, patients, and peers. interrupt toolkit. So this is actually, you can, I found, this is actually where I found this. Inquire, non-threatening, take responsibility, empower, reframe, redirect. We use impact questions, paraphrase, teach by using I phrases, inquire, encourage elaboration, leverage curiosity. I'm curious what makes you think that. Use those kind of words. Non-threatening, convey the message with respect. Separate the person from the action or behavior. Some may consider the statement to be offensive. Some may consider that a statement to be offensive. Communicate preferences rather than demands. It would be helpful to me if you expanded on that thought a little more and those kind of things. Take responsibility. If you need to reconsider a statement or action, acknowledge and apologize if necessary. Address microaggressions and revisit them if they were intentionally unaddressed. Let's just go back. Let's talk about that a little more. Empower, ask questions that will make a difference. What could you do differently? Reframe. Have you ever thought about it like this? Redirect. Helpful when an individual is put on the spot to speak for their identity group. Let's shift this conversation. Yeah. Use impact questions. What would happen if you considered the impact on? Paraphrase, make what is invisible, unconscious bias visible. It sounds to me like you think, whatever. Teach by using I phrases. Speak from your own experience. I felt X when Y happened, and it impacted me because. So explaining. So basically, the key messages of this lecture. So the U.S. struggles with a legacy of racism, and we've talked a lot about that. And all levels of racism can affect health and access to opportunities and wellness. Unconscious bias plays a significant role in shaping healthcare disparities, and there are ways to mitigate and address this. Despite our best intentions, high stress atmosphere in healthcare can mean microaggressions that can and often do occur. There are productive and meaningful ways to address these as well. Addressing the effects of racism and bias on health can help you be a better doctor, a better public health advocate, and a better healthcare team member. So that is it for this lecture. And I just want to also address some of my own issues with this, except I'm kind of there. So I'm not, you may have noticed, this is not the most comfortable topic for me. I've been on both sides of this topic, but I don't feel like I am maybe the best person to always teach this. But also knowing that is why I'm trying to get around my own issues with this. I find this topic to be very uncomfortable, and the things that we've done to populations and continue to do to people just makes me very upset. And so I do have issues when I'm trying to explain this topic. But knowing that is why I have to continue, and we all have to continue to address racism and sexism within the health system. I haven't directly really talked about sexism, and it's again been embedded. I did upload a TED Talk for you to watch. I think she does a great job of really talking about some of these issues. And so that being said, I hope you learned something. So we actually won't be talking about this until after, or having our class discussion on this until after spring break. So I wanted to get this up and kind of let you think about it a little more. On March 17th, we will have guest speakers talking about discrimination in housing in our local area. So I hope you all can make it for that talk. I will be recording it, so it will be available to everyone. So enjoy the rest of your day, and I will see you soon.